In this video, we will learn most important evaluation management coding interview questions and answers. These are the very common interview questions you will encounter if you go to any interview, and also these Q&A are very helpful for freshers as well as experienced coders. After watching this session, if you like this, please click on like button so that I can create more videos related to question and answers. And also, if you want any topic, please mention the comment section of this video so that I can make one video. Our first question is, what is E&M coding and why is important? Basically, evaluation management coding is used for patient's visit, consultation and hospital services. Using the evaluation management coding, we will ensure accurate billing and compliance and reimbursement for physician services. As if you know evaluation management, each and every code is having the separate reimbursement. So based on your code, patient will get the reimbursement. What are the three key components of E&M service? Basically in E&M, we have three key components. What are those? History includes chief complaint, HPI, ROS and past medical history. So ROS means review of systems. Next, we have second component is examination. Basically, it is related to physical exam findings. And most important one is medical decision making. So where we need to use E&M guidelines in order to select diagnosis, management and complexity of the patient's condition as well as treatment. So what is the difference between a new patient and an established patient? So what is new patient here? New patient has not received any professional service from the physician or other QHP in the last 3 years. Okay, so established patient means within 3 years. So it is very simple. New patient means patient will not receive any treatment from the same physician or same practice in last 3 years. Established patient means so patient had received treatment from the facility or professional in the past 3 years. So greater than 3 years new patient, less than 3 years old patient or established patient. So if anyone looking for medical coding jobs in UAE, USA and India, please join in our WhatsApp group. WhatsApp group link is the description of this video. And also if anyone looking for same day surgery training, IPDRG training, SEC training, CCA certification training, please send WhatsApp message to 707-526-3939. So what is our first next question? How do you determine the level of service in an office visit? Okay. So here we will check for three key components. What are those? History, exam and MDM. So we will code based on highest level supported by 2 out of 3 components. So here we will use 2 out of 3 components for highest level. So what is the difference between 99202 and 99203? Okay, so 99202 new patient, low to moderate complexity, 20 minutes typical. So if you want to code using that time for 99202, it is 20 minutes. For 99203 new patient, moderate complexity, 30 minutes typical. So minimum 20 minutes 202, minimum 30 minutes 203. And complexity is 202 low to moderate, 203 moderate complexity. So what is HPI? So HPI is a detailed description of the patient's current complaint, including location, duration, severity and context. What are the histories in E&M coding? So basically we have 4 histories: problem focused, chief complaint only, expanded problem focused, chief complaint plus brief HPI and ROS, detailed chief complaint plus extended HPI plus ROS plus PMH, comprehensive is complete history covering all systems. So again, thanks for watching this video. If anyone looking for surgery, IPDRG, SEC, CCS training, please send WhatsApp message to 707-526-3939. What are the elements of MDM? So we have 3 elements in MDM: number of diagnosis or management options, data to review and risk of complications or morbidity. Next question, how do time-based codes work? So we will use time-based codes when counseling or coordination of care dominates the visit. So total face-to-face or total time determines the E&M code. So if you want to code using the time-based, it must be face-to-face with patient to the physician. Next one, what is prolonged service code? So most of the time we will use prolonged service code longer than typical time for given E&M code. Okay, and must document start and end time. For example, in one code we have like 70 minutes for the highest time. So after 70 minutes, if the patient performs any type of evaluation management, we will use prolonged service code. Concept of key components in E&M coding. So as usual, as we have discussed previously, history, examination, MDM. So the E&M code is selected based on these components. So what is the difference between 99214 and 99215? So previously we have seen new patient, correct? So these are the established patient. So 99214 established patient, moderate MDM, 25 minutes typical, means 25 minutes minimum if you want to code using the time based E&M coding. So 99215 established patient, high MDM, so 40 minutes typical. So minimum 40 minutes needs to be having the face-to-face encounter between patient and physician. If more than 40 minutes, we need to use prolonged service code. So what is the significance of counseling and coordination of care? Okay. So what is the answer here? If more than 50% of visit time is spent on counseling or coordination, time-based coding can be applied. So what is preventive visit versus problem-oriented visit coding? So preventive visit codes are 993812, 99397. So basically these are annual wellness exams. Next we have problem-oriented 99202, 99215. These will address specific complaints related to the patient's current condition. So what is concurrent versus subsequent hospital care? So concurrent means multiple providers see same patient same day. Only one may bill full E&M. Subsequent means follow-up visits after initial hospital admission. So for subsequent visits we will use 992312, 99233. So what are the documentation required for home health E&M coding? Chief complaint, HPI, physical exam, MDM, time spent face-to-face, and home visit details. How to code if multiple problems? So we need to code based on highest complexity of the problem. Use MDM and risk to select code. Document all problems and management. So how do we use 25 modifier in E&M coding? So we will use 25 modifier when significant, separately identifiable E&M service is performed on the same day as a procedure. So what are the common mistakes in E&M coding and how to avoid? Answer is, what are the common mistakes? Wrong patient status, incorrect code level, poor documentation. So we need to avoid. Always review history, exam, MDM and document clearly. So thanks for watching this video. If anyone looking for surgery, IPDRG, SEC, CCS trainings, please send WhatsApp messages to 707-526-3939. And also if you like this session, please click on like button.